I wanted to make some focused comments today about the budget, Mr. Speaker, to do with reproductive health care. Over the last several weeks, we spent a long time looking at the budget and examining the estimates. In the NDP, we also have been getting back a lot of FOIPOP requests about the state of health care in our province. And just yesterday, the Standing Committee on Health met and discussed sexual health and reproductive health in Nova Scotia. So, I would like to, as I said, make some comments about reproductive health. That is, health care around things like cervixes, uteruses, ovaries, and fallopian tubes, and all of the hormones and other bodily functions that relate to these organs. If I want to make generalities, Mr. Speaker, I would say that mostly what I'm talking about affects cisgendered women. That is, women who were assigned female at birth and who identify as women. And that's an issue, Mr. Speaker. The underfunding, the lack of attention and lack of understanding to these issues, I would argue, is a form of gender discrimination. But also what I'm talking about, it also affects trans men and gender fluid or non-binary people. And for these folks, this is an even deeper issue because their access to queer or trans-friendly health care may be much more difficult. Many don't have the confidence in our healthcare system or the health professionals that they encounter that they'd be able to work with them to offer them the care that they need. So I want to go, I've been thinking about women's health or reproductive health for quite a long time, and I want to sort of go through the ages. So I'm going to start with period poverty, Mr. Speaker. Period poverty is a real thing, and I would expect that it will get worse as the cost of living continues to increase and all products are becoming harder to afford. Menstrual products are expensive, and there are many people who menstruate who simply can't afford the products they need. We in this House have the ability to address this issue and mandate that all public buildings provide menstrual products in all washrooms, not just for employees in those buildings, and that all workplaces provide menstrual products in workplace washrooms in the same way that washrooms are outfitted with toilet paper and hand soap. It's easy to do, and it's not expensive. But the impact would be huge for folks who live in poverty and are often trying to figure out how to stretch their dollars. And it's also huge for people who menstruate who forget their tampons or don't realize their period's going to start or whatever. And I'll get to that in a little while, just a second. The next thing I want to talk about is access to birth control and contraceptives. Mr. Speaker, in Nova Scotia, there are significant barriers to accessing free birth control. Contraceptives are basic preventative health care that should be free and easy to obtain. We heard from experts yesterday at Health Committee that there needs to be choice in contraception so that people who need it can get what's right for them. The June 2019 final report of the Advisory Council on the Implementation of National Pharmacare, established by the Government of Canada, pointed out that approximately 20% of Canadians have inadequate drug coverage or no coverage at all. The direct cost, Mr. Speaker, of unintended pregnancies has been estimated at $320 million per year. And that's in Canada. And we know that there is a proven link between income, age, and use of contraceptives, indicating an affordability challenge, particularly for young people. There are multitudes of organizations advocating for access to free contraceptives. The Canadian Pediatric Society, Action Canada for Sexual Health and Rights, Canadian Association of Midwives, National Aboriginal Council of Midwives, Canadian Medical Association, and the Society of Obstetricians and Gynecologists of Canada. So that's a pretty heavy-hitting expert saying that we need free birth control in Canada, in Nova Scotia. But speaking of birth control, let's go to the other side of that issue, which is fertility, Mr. Speaker. The tax credit that this government has brought in this session is good. I would never, ever say that it wasn't good. There are so many people who have contacted me, both as health spokesperson for the NDP, but also as a constituency MLA, who are struggling so much to be able to conceive a baby and to carry a baby. And that is expensive stuff. Mr. Speaker, I have here just a bit of the menu of the Atlantic Assisted Reproductive Therapies Clinic here, and I initial assessment $200. Okay, if you're experiencing infertility problems, maybe you can scrounge up $200 for an initial assessment. Sperm functional analysis. I'm going to say some words that might make people squirm. So sperm functional analysis, $295. Okay. Then we get into the actual more treatments. So therapeutic donor insemination. So that's when you don't need any help except for inseminating, like putting donor sperm in you. Turkey baster. $950. But, Mr. Speaker, the sperm is very expensive to obtain. So I have a friend who just bought sperm online last night, $4,000 for 3 vials of sperm. I said, how much does that get you? 3 vials is 3 tries. 3 tries at insemination, $4 grand. No one's covering that cost in any way, shape, or form. And then we get into the more complicated things. IVF, $8,100 to try. What? Not including the drugs. IVF with ICSI and anonymous donor sperm, $10,000. There's something that's $13,000.
Order, please. There's quite a bit of chatter around the chamber. I recognize the member for Dartmouth North.
Thank you, Mr. Speaker. You get my point. It's extremely expensive. And a tax credit is great, but it's only going to be great for the people that can afford that astronomical cost in the first place. You'd have to do a second mortgage on a house if you're lucky enough to own a house by the time at the age that you're trying to have a baby. You'd have to take out a massive line of credit. Or, better idea, Mr. Speaker, let's make fertility treatments insurable services under MSI. So people who want to need help to conceive or carry a child can walk in and get the help in the same way that they could get their leg put in a cast if they broke their leg. It only makes sense, especially in a province that is trying to double its population in, whatever it is, 40 years by 2060. 2 million people. Well, here's an idea. Help people have babies. I mean, all the other things are important too. Immigration, of course, blah, 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 blah. But yes, also, let's not put barriers in front of people to have children. Yeah. So then I want to talk a little bit about, the inner parts, the parts that are carrying babies or making babies. And the people that are suffering from chronic pain, chronic pelvic pain and endometriosis. Mr. Speaker, in this budget, there is no new money to address endometriosis or chronic pelvic pain, and I just want to tell you a little bit about what that is. So endometriosis is a gynecological condition that affects approximately 1 million people in Canada, 1 in 10 women, and unmeasured numbers of transgender and gender nonconforming people. Common symptoms include severe menstrual pain, chronic pelvic pain, infertility. There's neither a definitive cause nor a known cure for endometriosis. Symptoms are managed using a combination of medical and surgical care, and despite the burden of endometriosis, awareness of the condition is low because of menstrual stigma and taboo. So I'm going to say this. Menstruation. We have to be able to say these words and not worry about the stigma, Mr. Speaker. And the reason that so much of this health care has been overlooked for so many years is because it belongs to mostly women or people who menstruate, people who have uteruses. So it's a problem. I also want to talk about midwives, Mr. Speaker. Based on a meta-analysis of data from 13 studies involving a total of 16,000 women, researchers from King's College in London and a bunch of other universities in the UK recommend midwifery care as the gold standard for low-risk pregnancy. Maternity care that involves a midwife as the main care provider leads to several positive outcomes with no adverse effects for both mothers and babies. Several countries, like the UK and Australia, midwives represent the main providers of care for women during pregnancy, labor, and birth. And when midwives were the main providers of care during pregnancy, women were less likely to give birth prematurely or lose their babies before 24 weeks of gestation. Women were reported to be happier with the care they received, had fewer epidurals, fewer assisted births, fewer episiotomies, or surgical incisions that is the same thing, surgical incisions to reduce the risk of a tear. third-degree tears, both babies right here, folks. Based on these results, the researchers concluded that all women should be offered midwife-led continuity of care unless they have serious medical or obstetric complications. Midwives are not primary care providers, Mr. Speaker, but they are maternal care providers, and their presence would greatly relieve the pressure on many primary care providers, family doctors who follow pregnancies and deliver babies. The minister said the other day that midwives can't do surgery, and that's true, I guess. I actually didn't know that, but I believe her. But the fact is that there would be less surgeries if we had more midwives, because there would be less C-sections happening. It's a fact. It's completely proven. So we feel in the NDP there needs to be a major investment in expanding the midwife program. We need to have 80 midwives practicing in Nova Scotia in all areas of the province, so anyone who wants access to a midwife can have one. And think about that upstream. That is upstream healthcare, Mr. Speaker. Lastly, I want to speak in my last 3 minutes about menopause, Mr. Speaker. Another dirty word. Lots of taboo about menopause or perimenopause. And the reason I want to talk about this is, Mr. Speaker, because I am personally experiencing perimenopause. Thank you so much. It's awesome. It's really exciting. But seriously, this is an important part of reproductive health care. I don't know much about it yet because I am just sort of, getting into it. But I do know that I have been prescribed antidepressants because of it, and they help. And I'll say it loud, and I'll say it, proud that that is something that has happened to me over the last 2 years, and I don't want to push them on anyone, but I would say don't be afraid of them. And I want to demystify reproductive health care around menopause. So I'm going to look more into it, and I'm going to talk more about it in the next 4 years until the next election, and maybe I'll have a chance after that. So, Mr. Speaker, I will leave it there for today. It is my job to bring light, to bring to light issues with this budget and with policy in general. And I would say that based on all of the things that I brought up today, that we need significant attention and investment in reproductive health in Nova Scotia. This budget doesn't hit the mark. Let's be better. Thank you.